Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. It is truly an honor, also a privilege to sit here and to in one podium with my honored and my honorable teacher, Dr. Daniel and Dr. Irmalita. Okay, this is let's make it fun because it's getting afternoon and a little bit less crowded people here now, but I hope that we can learn something. The committee trusts me to bring the lecture, the role of high sensitivity troponin in the management of acute coronary syndrome. Well, definitely the high sensitivity troponin or troponin is become the most powerful and one not debatable as a parameter in building diagnosis of the acute coronary syndrome. And but there are some circumstances that perhaps we can learn or we can criticize, and why we need to improve more and more day by day. Then we can make a better diagnosis and to build the diagnosis for our patient. The cardiac troponin discovered in 1965 and worked with calcium ramps to facilitate muscle contraction. There are three subunits. There's troponin T, I, and C, just like what we know like this past 10 until 15 years. And then troponin I and troponin T are found almost exclusively in down myocardium, but the troponin C, perhaps we found it mostly in calcium. And then half-life of troponin is approximately 2 hours, and 45% of cardiac troponin is found as a free protein in the cytoplasm. Cardiac troponin release mostly because of the myocardial injury. There are two phases when this enzyme will be released. There's a first phase and a second phase. The first phase is the initial increase in serum troponin due to release from cytoplasm. Usually happen with the myocardial infarction, and then the secondary rise from decaying myocardial contractile apparatus. Usually slower, gradual, and continuously, and happen like other chronic myocardial injury cause, like tachyarrhythmia and cause as well. So between the high sensitivity and sensitive cardiac troponin, what is the difference between these two? The sensitive troponin, the conventional one, the old one, is allowed for the detection of cardiac troponin in 20 until 50% of healthy individuals. But high sensitivity can allow to detect the cardiac troponin in until 50 until 95% of healthy individuals. And the high sensitivity assays are recommended because nowadays there are a lot of high sensitivity assays, and then from those parameters you can choose the high sensitivity assay recommended over lower sensitivity assays, as they provide higher diagnostic accuracy at an identical low cost. So why choose the conventional one if the cost is the same? This is from the economic point of view. And then the other reason from the scientific view why we need to choose the high sensitivity cardiac troponin, from the EC 2020 they say that this is compared with standard cardiac troponin assay. The high sensitivity troponin assay have a higher negative predictive value. So this is more accurate for the acute cardiac infarction, and it is could reduce the troponin blind in interval leading to earlier detection of acute cardiac infarction. And then this result in 4% absolute and 20% relative increase, which is in the type 1 MI, the gray area we can describe whether this is normal or this is not normal. So we can just choose whether this patient is need to go for further evaluation or not. And level of high sensitivity cardiac troponin should be interpreted as quantitative markers. It means higher the level, the greater the likelihood of myocardial infarction, or the greater the impact for the myocardial injury. And raising or falling cardiac troponin level could differentiate acute. This is the most important way, because the delta or the change between the initial and the second one can make a very good distribution to see whether this patient could be ruled in or could be ruled out. This is the difference between the conventional one and the latest one, the high sensitivity assay one. The difference is the high sensitivity assay is more accurate because of its lower or smaller particle, which is in nanogram per liter, if we compare with the microgram per liter in conventional assays. As you can see, there are a lot of gray area in the conventional assay, but in the high sensitivity assay, that can be determine whether we need to do the pathological way or this is the non-economic function. And this is how we need to diagnose the acute coronary syndrome, because there are a lot of spectrum from the unstable angina, stima, and also perhaps coming with the cardiac arrest, for example. And the important way is, especially in the non-STHS, we need to differentiate which one we need to treat, because there is no moderate high risk. Nowadays, the non-STIMI should go either for immediate one or the low risk one. And this is the recommendation for clinical and diagnostic tools for patients with suspected acute coronary syndrome. From the blood sample, you can see it is recommended to measure cardiac troponin with high sensitivity assay immediately after presentation and to obtain the result within 60 minutes of blood sampling. It means we don't need to wait until the result comes, then we can apply to the strategy. Is it 0, 1 or 0, 2? It is recommended to use an XT algorithm approach to serial high sensitivity cardiac troponin measurement. We need to choose whether we want to choose 0, 1 or 0, 2 to rule out and rule in non-STIMI. And additional testing after 3 hours, it is recommended to, if the first two high sensitivity cardiac troponin measurement of the 0, 1 algorithm are inconclusive or we cannot see whether this is to rule in or to rule out, then we need to do the third examination. So rapid rule in and rule out algorithm. Best option is of course 0, 1 algorithm, and the second best is 0, 2. This algorithm based on two underlying concepts, which is the high sensitivity cardiac troponin is a continuous variable. So and it's always increased, and early absolute changes in the level within 1 or 2 hours can be used as surrogate absolute changes over 3 hours or 6 hours and provide incremental diagnostic value to the single cardiac troponin assessment and presentation. So this is the differentiation between now and perhaps 10 years before. 10 years before, we need to wait until like 2 hours after the onset, and then after 2 hours, then we can check, because the cardiac troponin conventional way wait until the onset. But nowadays, the high sensitivity troponin is no longer applied in that situation. Those people we assume that suspect to have the acute coronary syndrome, we can check directly the high sensitivity cardiac troponin. Then we can apply whether this is the 0, 1 or 0, 2. If you want to apply 0, 1, do not wait until the first result came out. Just check the laboratory at 1 hour after the first initiate. And if you want to apply the 0, 2, just perform the blood sample in the 2 hours. And this is how we want to read it. Whether the patient very low at initial or low initial changes or delta, and then we can rule out the pathway. And if the high initial, high sensitivity cardiac troponin or increase in the 1 or 2 hour has the cardiac troponin or the delta is correct, and then we can rule in pathway. So based on this, we can see it depends on what assay specific kind of level. You can see there's a very low, no delta 1 hour and high and delta in 1 hour. In cardiac center of Argentina, we use the approach based on the information from EV, and in my hospital we use the M1. Both are quite good, because you can see if there's a very low, then there's no delta, then we can rule out of the patient. But if there's high, and then also the delta, we can choose the patient in. But if not meet in the criteria, we need to check it again for the third examination. This is the conference of cardiac troponin concentration. Can be because of the age, renal dysfunction, time, and also for the gender. Before, it was this cut-off for specific for the partial diagonal function. In high sensitivity cardiac troponin, there's no cut-off in these methods because somehow the delta can expand as well. Then we can rule in or out of the acute myocardial function, especially in non-CM. This is condition other than type 1 MI associated with cardiovascular injury. Could be from tachypnea, myocarditis, pulmonary embolism, hypohyperthyroidism, heart failure, tapetubo, renal dysfunction, infiltrative disease, progressive emergency, structural heart disease like aortic stenosis, acute neurological event, myocardial toxicity like deep oxygen toxicity, and critical illness, hospitalization, cardiac contusion, and also extreme endurance effort. The take-home message is high sensitivity cardiac troponin is more recommended than the conventional one as a biomarker for diagnosing MI patients, and 0-1 power or 0-2 algorithm is recommended for establishing non-CMI diagnosis. It's okay whether you want to choose whether the first one or the second option. And cutoff value of high sensitivity cardiac troponin is dependent on the ACS, and increasing of high sensitivity cardiac troponin also can be found in cardiovascular injury. And hence, the accurate taking history of ECG interpretation are mandatory to see what the diagnosis is being. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.